Hi, good afternoon, everyone. My name is I-Ting. I'm one of the two social workers at the Jerry Site Clinic. I'm here today with Miss Clivia Torres. So today we will be going over the social work services, and we hope that after today's presentation, you will have a better idea of what are the resources and not only available to our patient, but also for other patients that you may have come across later on in your rotation. Okay, so this presentation is supported by HRSA. HRSA, the U.S. Department of Health and Human Services, and the CED, which is a grant from New York State Department of Health. There's no conflict of interest. Our clinic is following the age-friendly healthcare model, the 4Ms, which are matters, medication, mentation, and mobility. So during our patient visit, we usually ask and screen all these 4 questions. And we are Cleveland and I work in this interdisciplinary and interprofessional team. We usually join our patient intakes and to assess and determine the family needs. And our responsibilities include providing concrete services and advocacy, care management, and resource linkage. And we thought that it will be helpful that we have this presentation before, because I know for PC2 and some of the medical students, today is your first day at the clinic. And we thought this information would be helpful to you because I believe you will come across patients that are asking for some of the social services and most likely the home care referrals and the healthcare related questions. So today we will be covering the process of home care, the programs that are available under Medicaid, social services in the community, advanced directives, the caregiver initiative programs in New York City. So what is home care? Home care is a health service provided in the patient's home to promote and maintain and restore the effects of illness and a disability. So services may include the nursing care, which includes the speech therapies, physical therapies, occupational therapies. There's also home health aid service and personal care services. And the care also requires assistance for activities of daily living and instrumental activities of daily living. So as you may know, as the symptoms of dementia progresses, patient can become more dependent on their ADLs and IADLs, and they may require more support from the caregiver and home attendants from anywhere from 1 hour a week to 24 hours per day. And actually, we have received so many requests for an increase of home care hours throughout this pandemic. And we always advise the family if they are asking for or requesting for more hours, they should examine based on the patient's ADLs and IADLs. For ADLs, activities of daily living includes bathing if they are able to take off the clothes, get into the bathtub, measure water temperature. If they need assistance in this process, then you would need the help. You would tell the nurse who is doing the evaluation that the patient needs the bathing assistance. For dressing, can the patient dress according to the weather without prompting, or you have to pick it out from the closet and put it on for them? Do they need help with grooming, mouth care, toileting? Do they know how to flush the toilets? Or you have to supervise and assist with the toilet's personal hygiene? Do they need assistance transferring to bed, to chair, or to places? Are they using a can, walker for mobility? Do they need reminder to eat, or you have to cut into pieces for them to eat? So that's part of the ADLs. For IADLs, that includes the shopping, the cooking, medications, reminders of medication. If you're the healthcare proxy or caregiver, you can administer the medication. But for home health aid, you will be mainly doing the reminders, reminding them to take medication. Can the patient use the phone call? Can they make their needs known? Can they do laundry themselves or taking public transportation to their appointments? and managing finances. So those are under ADLs and IADLs. So if the patient needs those assistance or they become more dependent on this, then yes, you should be asking for an increase of hours. However, we also have been getting requests for companionship or for safety. So unfortunately, the home care, the nurse, the MLTC, they would not approve the hours based on the safety. They would automatically deny the request, stating that it's medically not necessary. So everything they look at is the concrete needs. And in order to get home care in New York State, the only way to go about it is to apply for Medicaid long-term care. Unless you're doing it private, you can have an option of private pay someone to provide the home care assistance. But for the most of our patients, they will have to enroll in the Medicaid long-term managed care. So for Medicaid in New York State, there's an income threshold. In 2021, this year, the income threshold for an individual is $904 a month. That includes the Social Security, pension, or you have any bonds, all of those consider your income. For a couple, it's $1,320 a month. And you cannot have assets as an individual, you cannot have assets more than $15,900. For a couple is 23,400 for a couple. So if the patient has more than 904 a month, we will then suggest there's two ways to go about. One is spend down or pooled income trust. So for spend down, you will go to the Medicare office or the Social Security office in the city, and you make appointment and have them look into your income and finances, and whatever you have left over, the surplus, you will surrender the amounts to the state. Then you become qualified for Medicaid. But if someone who has more surplus, more money, they tend to not do spend down, they should consider doing the pooled income trust. So pooled income trust, I think, is also only available in New York. They have this program. It's run by the nonprofit organizations. So the way they do it is that the surplus you will put in the pooled income trust. You will keep the 905, the applicants, the patient will keep 904, and the remaining surplus you will put in a pooled income trust. And those money will be managed by the nonprofit organization. So one of the example, I can give you an example. So a person's monthly income is $3,000, and they only get to keep 904. So the surplus is $2,096. So then they have to decide to do a spend down or pool trust. Spend down, like I said, you will have to surrender and give up that amount of money to the state, which usually will advise they should consider pool trust with that amount of money. It's a lot to surrender. So the pool trust, you will put the 2,096 in the pool income trust, and then whatever bills that's under the applicant's name or the patient's name, you can submit the bills to this pool income trust agency. Sometimes there's a one-time fee, depends on the agency that you choose to manage your pool income trust. Some have a one-time fee or an annual fee of handling all this business for you, but it's better to get on the pool trust and surrender the amounts to the state, because technically the money is still yours. It just, you don't have the flexibility to withdraw the money from the bank like you used to be able to, but you can still pay the bills, the rents, the utilities, anything that's under the patients, then they can pay it for you. Okay, so sorry, I was reading the notes. So as I mentioned, there are two programs that's under Medicaid that can provide home care assistance. One is called Managed Long-Term Care Plan, and that's called Community Medicaid. And they look at the ADLs, well, they both look at the ADLs and IADLs. tend to be, they have more programs for adult day program under managed long-term care plan. And they have this called CDPAP, Consumer Directed Personal Assistant Program. So this program allows the family members or relatives or friends who patient is familiar with can be the one who is taking care of them while getting paid. So this is usually the program that a lot of family members end up going with because they can get some compensation while taking care of the patient. When they're applying for this program, the agency will require at least 2 persons to apply. One will be the primary caregiver, one will be the primary care, the personal home attendant who is going to be the primary person to take care of the patient. The other one will be the backup. In case something happens, they will have a backup. So the CDPAP program is quite beneficial, especially during the COVID time. The family can stay home and getting paid while taking care of the patient. The other one is called Nursing Home Transition Diversion Medicaid Waiver Program, and that is through the straight Medicaid. So this program, they're more generous with the home care hours. If you're looking for something that's like 24 hours, 7 days, this is probably a better program to go with. They usually give a split shift with 8 hours for 3 shifts per day. Instead of the managed long-term care plan, they usually give like 24/7 of living care. And you have to fight really hard with that program, managed long-term care plan. You have to fight really hard and go through the internal appeal in front of the judge. So eventually, if someone who is becoming more dependent on the ADLs and IADLs, we suggest a family to consider this program. If they are changing from managed long-term care plan to this nursing home transition diversion program, before they do transfer, they have to make sure the providers that are involved in the patient's care can take straight Medicaid. And they usually have to double check before they switch. Otherwise, after they switching and the provider who they used to see no longer take them, it will become troublesome and for the patient. So that's the reminder we always suggest the family to review before they make the change. So for Medicaid, there's also nursing home Medicaid, which is the family eventually decides to place a patient in a nursing home facility for long-term care. So this is different from community Medicaid. So community Medicaid allows the patient to remain in a home and receive the support from the home attendants. But for nursing home, they will be in the facility where there will be nurse and around the clock and the doctors. For nursing home Medicaid, they have a look back period of 5 years. Even for now, when you apply for Medicaid, and if this is something ultimately the family wants to do, then they should start planning because the Medicaid administration, they will look into the last 5 years of patients' income. If they see there is income more than the threshold, they will not necessarily the penalty, but they would charge the certain amounts before you become qualified for the nursing home Medicaid. For Medicare, Medicare is for someone who is 65 or older, and they do provide home care too. However, they only allow short-term care that usually take, I think, 6 to 8 weeks max per year. And that's usually offered after the patient get discharged from the hospital. They will be able to get on the short-term home care under Medicare. But if you are looking for long-term care, Medicaid is the only way to go.
Oh, I just want to finish this patient, then I just want to add something about Medicaid and Medicare.
Okay, so let me finish this slide.
Yeah.
Okay, so there's a new change coming to Medicaid. Before it was last year, they were talking about this to have this policy enacted in October, but because of COVID, they have postponed it, and now it postponed to January 2022. So starting in January next year, there will be a 30 months look back for the community Medicaid. So presently, there's no look back period. If you're interested in getting Medicaid, you can apply and there's no penalty or look back period when you apply right now. But starting next year, there will be a 30 months. That means that if you have any, before you apply for Medicaid, they will look into if you have any money that's above the threshold, if you have any assets that's above $15,000, then there will be a penalty. I'm not sure how much they will put for the fine. I'm not sure, but I think that it depends on how much money you transfer. Right? I think there's a percentage of how much you transfer, and then the penalty will be the amount of the amount you transfer. So we usually will suggest, if right now, if they come into us and we will inform this change, they should act quick if they decide to do it. You can transfer the assets to an exempt person, which is your spouse or a blind or a disabled child. So there's something called spousal refusal that only applicable in New York State and Florida. No other states have this spousal refusal option. So in New York State, if the couple who one of the for example, if the patient wants to get on Medicaid and then the spouse refuse to pay or responsible for any medical expenses the patient has, he or he should consider enrolled or have this spousal refusal set up. That will allow her any finances or any income she has will not be responsible, that she will not need to cover the cost of the patient's medical care. And that also helps patient to get Medicaid in a way, because sometimes when the patient stop working and then the partner has income or pension or any other income coming in, that will affect their eligibility to get Medicaid. So this will also help them, but it has to done with the elder law attorney. We will not be able to do this. The family has to speak to elder law attorney and authorize this. And then after they have this set up, then they can go to the Medicaid office and apply the Medicaid. Sorry, Cleva, you can go on.
No, I just wanted to know, because someone asked us to sort of mention Medicare and Medicaid and some of the things that are covered. So for Medicaid, I just wanted to mention that Medicaid does cover adult day programs in New York State and in New York City, that is, and meaning that the patient gets picked up at home and he gets dropped off at home. One of the requests from like the day program is that someone is there in the evening to retrieve the patient to make sure that they don't wander away. And Medicaid also covers home care, which is what I-Ting was talking about, which is one of the reasons we encourage our caregivers to try to get the Medicaid application process as soon as possible for the patients. And then they also cover some portion of the assisted living facilities. They also have programs for people with special needs. They cover medical care, hospital care, occupational therapy, physical therapy, and the medications. And then the Medicare is generally, like I-Ting mentioned, for people that are 65 and older, or if you're younger and you have a debilitation, you have a disease that's approved by Social Security / Medicare. So original Part A covers hospitals and medical facilities, hospital care, skilled nursing facility care, hospice care, the homes care, home health services, but it's short term, and then the nursing home care. And then the Part B, because with Medicare, you have different parts of it. Okay, they do cover, the Part B covers the doctor services or visits, like if you need a second opinion on a surgery, outpatient care, mental health, the medical supplies, the durable equipment, ambulance service, and the preventive services. So Medicare has Part A, Part B, Part C, and even Part D. But because we didn't include that in this talk today, because we just wanted to focus on the social services as social workers, what we do in our clinic. So
There's a
continue.
There's a question from Ms. Lisa Kim. How does this payment coverage system affect the ability of families and to generate intergenerational wealth when you need to be below the poverty line and receive this care? Or have
So
extra
that
term?
is one of the reasons a lot of people, what they choose to do is they use an elder attorney, because the elder attorney knows the rules and regulations to help protect, okay, the assets and the resources. In some cases, what they do is that they actually put the home in a trust, so Medicaid cannot go after it. Usually they do not go after it, but sometimes Medicaid does tend to go after the home, even though it's in a trust. But it's really, we recommend to our caregivers to always speak with like an elder attorney, because they're the ones that are best qualified to help protect the assets.
And
Okay.
also, I have one part of it wanted to add. So we usually would suggest a family to determine how many hours or how much care they think they need for the patient. Is it worth it to put a lot of money in the pool trust and when patient only needs a couple hours a week for lighthouse cleaning? Because some of the family, they don't want to give up that much money to the pool trust, and they don't have the flexibility to withdraw the money and have the control over it. So they ended up doing the private paid. And if, like you said, if they have a lot of money or wealth, they can either transfer, like if they have to transfer the house, or they can transfer the savings assets to their kids, or put into a trust so that the patient will become eligible, or just have a private pay so that you don't lose that control of your financial situation.
And private pay is becoming more expensive each day. Now it's about $25 to $30 an hour. You know, there was a time that it was like $15, you know, $20, but now it's a little more expensive. Next slide, I-Ting.
Okay.
Okay. So in terms of like resources that are available to caregivers and patients, next slide, please. All right, so for respite care, that's for short term. So usually if a patient does not have Medicaid and the family chooses to apply for it, or they're waiting for the application to be processed, we can refer them to Sunnyside. Caring Kind used to have short-term respite, or PSS. Actually, I-Ting and I met with Sunnyside last week, if I'm not mistaken, and she informed us that she was able to get a couple of hours, you know, she has several hours, 100 hours, let's put it that way, that she needs to use up by the end of December. Okay, because of the way that their contract and their grant was written. So she was asking us if we could refer families to her that are in that waiting period. So those are the patients that, I mean, the families that we referred. And respite care, like I said, it could be 12 hours a week. It could be 15 hours. It's only to help the family until the Medicaid application is approved, okay? As social workers in this clinic, I-Ting and I have also had to call APS, Adult Protective Services, for various reasons, some of which can include, you know, financial exploitation, you know, neglect and things like that. So usually in the past, you were able to actually speak with a worker and explain what your concerns were. Now, because of COVID, we have to technically we do it online. So we just make a referral, and then they contact us just to get like the key information, you know, family name, the patient's name, date of birth, address, and things like that. And then they follow up with those services. Go ahead.
Any providers too, any healthcare providers or they professionals, they can do APS referral, not necessarily be social workers.
Right. It technically can be anyone that comes in encounter with the patient, because if you let us know, then we become like the secondhand information, the second-hand reporter. And APS prefers, like ACS, when you're working with children, they actually prefer you to talk to the person that got the initial information. And then in terms of like programs for homebound patients or people that need food, there's a City Meals on Wheels. Okay, then there's another program called God's Love We Delivered, and Mom's Meal. Mom's Meal is about $7, if I'm not mistaken, a meal. So for some patients, that can be a little expensive. Okay, so that's why sometimes the families opt to apply for Medicaid so they can get a home care worker who can then cook for the patient. The challenge we have is that sometimes they do cook, but our patients forget to eat the food, or they forget how to use a microwave, so they're not able to eat. And that's when we have to write a letter of like medical necessity just to find the increase of home care hours. Next page, I-Ting.
Dr. Gerard has a question.
Oh, I'm sorry.
Yes.
I just wanted to be sure we reminded all of our new to be physicians, nurses, and other colleagues about the mandatory reporting laws. I believe New York does require us to report abuse and neglect.
No, unfortunately, I think New York State is for APS. No, we're not a mandated reporter, which is terrible.
We are ethically obligated, though,
yes,
to report.
Yeah. But
Ethically
New York
immoral.
New York doesn't have that legal requirement, huh?
It
No.
does not,
Wow.
unless
I'm
there's been an update that I'm unaware of. It's one of the
Yeah.
very few exceptions.
Well, let's talk about this at the ECHO session on Friday. We can get Senator May involved.
That would be great.
Yeah.
Okay.
I mean, we do it because we know it's our ethical responsibility to do so, you know, and just morally for me personally, you know, but that becomes a challenge. Whereas with ACS, it's a little different. When you're working with young children, you are a mandated reporter, but not for the adults.
Right.
Okay, next slide, I-Ting.
Okay.
Next slide.
Oh, it's,
Okay, I'm sorry. So in terms of, go back, I'm sorry. So in terms of transportation support, we do encourage some of our family, the caregivers, to apply for Accessoride, which is like a bus service or a taxi service that does pick up the patient. It does cost about $2.75, which is the regular price of a ride on a bus or a train. And what happens with that is, give me 1 second. Okay, right there. So what happens with that is that sometimes families do not like to use it because they complain that they have to wait a long time, that if the appointment is at 10 o'clock in the morning, they may pick them up at 8 o'clock in the morning and drop them off too early, or they arrive too late for the appointment, and then that the long period that they have to wait on the return home. However, for some patients, it does work, you know what I'm saying? And because if they don't have insurance, if they don't have transportation through their MLTC, which is the Medicaid portion of it, then they would have to do the Accessoride. We do know that a lot of them do have transportation service through their Medicaid, the managed long-term care, be it Fidelis, United, Health First, okay? Then in Brooklyn, there's also a program called the JCC, and they're based in Coney Island, and they do provide transportation for Brooklyn seniors and residents only. They'll take them to, like, most of the time it's medical appointments, but if they need it to go elsewhere, sometimes they're able to arrange it with enough notification. And then senior centers versus the adult day programs. So the senior centers, anyone that's over the age of 60 can attend and can participate, and they can take someone with them to the center. So if they have a home health aide, they can take the aide with them. If they have a family member, they can do that. Excuse me. With the adult day program, they cannot take anyone with them. So what happens is the patient or the person gets picked up in the home, they're transported to the adult day program, they spend the day there doing certain activities, and then they are brought back home. I do know I've spoken with some of the directors of the adult day programs, and they really would prefer someone to be home to receive the patient, because they don't want the patient to walk away or get lost or something like that. And they do a series of activities, the same as in the senior centers. You know, they play bingo, they, socialize, they sometimes have exercises. At the senior centers, they're able to get breakfast and lunch for like a reasonable fee. Maybe breakfast is like $1, lunch could be like $2.50 or $3. And some seniors, what they do is if there's extra, they can just take it home with them. and then they can have dinner. In terms of the public libraries, there are a lot of senior programs for seniors in the public libraries. You know, we've had patients and some caregivers that we refer to them because, you know, the patient still can, you know, is in the MCI stage of the disease, and they can still go to the library and participate in some of the activities. And we also met, we were trying to do a program with the Brooklyn Botanical Garden.
Right.
Okay, just this year we were trying to like do a day of activity for some of the seniors and the caregivers. Unfortunately, it didn't work out, you know, but we were trying to really work on that with them. In-home therapy, sometimes we have a lot of patients that want counseling. Okay, there's a shortage of counselors and therapists. So we do know that OHEL does have a program that they do short-term, either by phone or in person. It's usually 6 to 7 sessions. There's also Integrity Senior Services. And in our clinic, we do have one doctor, but he doesn't have any more availability right now as we speak. And then if not, what we tell the family member is to contact the PCP either for a referral or to call like the insurance and see where they can refer the patient to. In terms of Social Security, that's usually given to someone of retirement age. Okay, and then if you become disabled, you can also get Social Security disability. Before you're the age of 65, you can collect Social Security at the age of 62, but most people try to wait until they're older so they can get the full benefit, which is generally reached at age 70. SSI is a program that's given to patients or people when they do not have enough quarters of Social Security. So to get Social Security, you would need 40 quarters or 40 credits. That's how they count that. And so it's basically 10 years of uninterrupted work. And then in SSI, if you don't have those 10 years of uninterrupted work, but you're disabled, then you may qualify for Social Security, for SSI, that is. Okay. For the Citizenship Waiver Program, we actually have many patients that come to our clinic, okay, because they want to complete the citizenship application, and you know, because they have dementia or because they have memory problems, they're unable to recall the information to pass either the written or the verbal test. So we do complete those, but we expect to see the patient several times because we really have to put like all the dates that the doctor has seen the patient, like, you know, what is the therapy or what is the form of treatment, the mode of treatment, and things like that. So the form, I think, is about, give or take, about 10 pages,
Right.
if I'm not mistaken. So it's very thorough. So we try to tell the patient to come back several visits so we can at least have a lot of information and documentation. And then it has to be signed by the doctor. And if there is someone that interprets or translates, they also have to sign. The FMLA form, sometimes we have family members that come to us asking us to complete the forms. So generally speaking, I-Ting and I will complete the forms and then we share it with the doctor who reviews it, makes any changes and signs off on it. Okay, we are the ones that also work with the doctor and with the family to do the letter of medical necessities too. And we recommend to the patients and the caregivers, do not ask for several letters. It's best to just request one letter because it doesn't look good when a doctor's writing a letter, let's say just for like the initial appeal with the internal appeal. And then like, let's say a month later, now they want another letter for the external appeal with the judge. So that's usually a conversation that I-Ting and I will have with the family member. And we usually have it together with the family member like that. If either one of us is not available, we sort of both remember.
Right.
Next slide, I-Ting. In terms of housing, seniors housing, we know that there is a big shortage of it. There is actually a lot of new affordable housing going up in the city. However, people have to apply for it. Okay. And it's an application. It has several key questions like your name, address, your income, source of income, any medical conditions and things like that. So we actually tell people to try to go on to like the Housing Connects, which is basically a lottery. And we have 1 or 2 patients that have been matched to the lottery, but that's really one of the surest way to try to get housing. In terms of New York City housing, they have those are the projects, you know, that tall buildings, but they have a long waiting period. And I think it's about 10 years to try to get that. It's the same like if you do Section 8 housing.
Mhm.
Section 8 had closed down for a period. I heard that it reopened, but I know it reopened in Long Island for a brief period and then it shut down again. So I don't even know if it's currently active in or open in New York, because that just gives you like a window to apply. Shared housing, it's a program through the New York Foundation for Senior Citizens. Basically, like if I have an extra room and I want to bring in another adult into my home, they try to match us based on, likes, interests, and things like that. And then we sort of share the bills. And the shared resident is the same thing, but it applies more to people that may have, some kind of disability, where they may have someone overseeing the unit. They may have like a house with like 4 apartments, and in each apartment, someone may live there, but they have people that oversee their activities, and if they have home care and things like that. Next slide. The North, those are like communities that are naturally occurring retirement communities where people sort of age in place. They've been living in the community for a long time. And as they age, they get classified as a North community. Actually, I-Ting and I just did a presentation, I think it was last month, to a North community, and we came across one of our former workers. So it was rather interesting. And then the homeless shelters and for men, the homeless shelters, it's in Bellevue Hospital. Okay, and for women, you have 2, the one on Williams Avenue and then the one on Franklin Avenue. Franklin Avenue in the Bronx. And then they do have shelters for veterans, but they don't have enough of them. And it's usually the men. I do know that there's one in Brooklyn, and it's really difficult to get into it because you first have to go to the men's shelter at Bellevue to then be classified as a veteran. So you have to have all your documents, and then they try to transfer you to the VA shelter, the veterans shelter. And it's really difficult because they have a shortage of space. Excuse me. Next slide. Advanced directives, that's basically a legal document by which you make provisions for your future health decisions in the event that you're not able to do so yourself. So, we tell our families when they come to our clinic, try to get, if the patient has the capacity to complete the healthcare proxy and even the power of attorney. I-Ting and I can do the healthcare proxy in the clinic if we're told that the patient has the capacity to do that. And it's basically who the patient wants. Okay, so that's why it's important that the patient has the capacity to appoint whoever they want. There's a living will, okay? And then, we have a discussion. Does the patient want to be resuscitated? That's something that they have to take into account as part of their final wishes and things like that. I-Ting and I cannot do the power of attorney because that needs to be notarized. And it has to, generally, we tell them to either do it with a notary public, or they sometimes, some families come to us and say, we already have it. They may have done it, let's say, before the patient became ill or started developing memory problems. Like I said, the living will allows you to leave your written instructions that explain your healthcare wishes, especially, excuse me, and a life care. And you cannot use the living will to name a healthcare agent. So you must use the healthcare proxy form, okay? And the do not resuscitate, that's a medical order written by a doctor. We also encourage the families to complete the MOLST, the MOLS form with their doctor, okay? I do know that we've completed 1 or 2 in our clinic when we've had a discussion with the family. And then the guardianship. So if the patient, let's say, does not have the capacity and there's a lot of disagreement among the family members, okay, and there's no one that has been appointed as the healthcare proxy or the power of attorney for the financial resources and things like that, then they need to go and do a guardianship. And that can be very expensive, okay? So sometimes they have to go to court to request guardianship. There are times that an attorney can help them do that, but it can be very, very expensive. Excuse me, next slide. And some of the caregiver programs that we partner with and we refer to when our caregivers need assistance is Sunnyside Senior Social Services. Okay, and they're located in Queens, but they do service the city. And then it's also Presbyterian Senior Services. They're based in the Bronx, but once again, they service the whole city. There's Caring Kind, and they're located in 40th Street in Manhattan on Lexington Avenue. Then there's the Alzheimer's Association, and they're also located on 42nd Street in Manhattan. And then we also have had training, and we've attended some of their functions of the Alzheimer's Foundation of America, and they're located on 28th Street on 7th Avenue. So, and those are the, go ahead, I-Ting.
Some of the services they provide include like the caregiver support, additional to what Clivia mentioned about the education and training. They do caregiver support. In the past it was in person, but now via phone or on Zoom. They also provide activities like chair yoga or drawing type of different
Jazz,
and jazz
gardening.
music. For Caring Kind, we usually use Caring Kind for a medical ID bracelet. So as mentioned earlier, Clivia and I joined the first intake, and the doctor will let us know if the patient is at risk of wandering or if they had wandering episodes, then we will be applying for a medical ID bracelet for the patient. So usually it's a stainless bracelet with 2 latches. But if family wants something that's more high end, like we usually refer them to Sunnyside. They have like a GPS watch which they can track the patient. It's just the patient has to put the watch on all the time so that if they wanders, the family can use the Wi-Fi or data to track where the patient is. So these are the 3 the agencies that we refer for caregiver support. Any other questions? I think that's it, right? Yes.